It's now been 50 years since the first successful transplant was reported, and more than 40 years since the first 100 patients with refractory acute leukemia was reported by Dr. Don Thomas in the Seattle group. And I think we forget that in that series of the first 100 patients, the oldest patient was 35. And although, the great success was that, 25% of the patients were alive without disease 10 years out, there still was significant morbidity and toxicity. There's been significant advances in the field over the last 50 years. Mortality rates have halved and now are routinely less than 10% over the first 6 months, and less than 20% in the 5-year period for people with standard risk disease. The average age of transplant has gone from 25 years to now more than 55 years of age. But there's still significant room for improvement. Relapse remains the most important cause of treatment failure, but toxicities are still a major issue. We have made some strides with personalized drug dosing, intravenous busulfan being the first example of how personalized drug dosing avoids overdosing, which causes toxicity, and underdosing, which may contribute to relapse. Recently, the group at Ullrich, the pediatric group led by J.J. Bolins, who's now at Memorial Sloan-Kettering, also showed the impact of personalized ATG dosing on potential improvement in transplant outcomes. Mike Scordo from our group is doing the same now for adult patients with ATG, having published a retrospective study showing again that ATG overexposure results in slower immune reconstitution, a higher risk of infection, and increases in non-relapse mortality.